Okay, good morning, everyone, and welcome to this week's Urology Breakfast Webinar. Thank you all for joining this morning. We have another excellent program lined up today. We'll be focusing on advances in uro-oncology and the evolving role of minimally invasive treatment options for renal masses. So our first speaker this morning is Dr. Santhuri Viranna. Santhuri is a consultant radiation oncologist here at Groote Schuur Hospital. Many of us know Dr. Viranna through an integral role within our multidisciplinary uro-oncology team and her involvement in coordinating the LE34 oncology meetings where complex urological cancer cases are reviewed and discussed. Today, she will be presenting on the uro-oncology highlights from ESTRO 2026 with the topic New Directions in Radiation Oncology. So for those unfamiliar with ESTRO, ESTRO is the European Society of Radiation and Oncology Congress. And it's one of the leading international meetings in radiation oncology. And it brings together experts from around the world to discuss the latest developments in cancer treatment, research, and technology. So Dr. Viranna, we look forward to your talk this morning. You can go ahead. Share that.
How do you start it? F5? No?
Yes. Do the full screen and we paste at the bottom. But you set it.
Is it projecting?
Oh.
Where is it? How do you hide this bar? What's going on now? Yeah, there we go. We just got to slideshow.
On that original slide and shape like that.
Yeah, I'm trying, but no. Oh my word. Oh my word.
Maybe those my slides, I think.
Nice.
Those ones.
Oh yeah, that's up to them. Shape. This one. Yeah. There we go. Okay, so then let's just go here and do. Does that show correct? Yes. There we go. Okay. Sorry about that, everyone. Good morning. And thank you very much for the introduction. Unfortunately, my slide format changed a little bit, so apologies for the font. But like Aman mentioned, I recently went to an international congress called ESTRO, and today I'm going to be giving some feedback on the uro-oncology highlights. Oopsie. So yeah, ESTRO is, like Aman said, a big society, the European Society for Radiation Oncology. They bring together all professionals that are involved with radiotherapy, so not only oncologists, but also medical physicists and RTTs. And there is an annual meeting. And this year's meeting was in Stockholm, in Sweden. It was in the middle of May, so a beautiful time to be in Stockholm in spring. You can see they have beautiful flowers all over the city with lots of waterways. I also managed to do some sightseeing before and after the conference. It's the land of the Vikings, so I'm quite into Viking and Viking history. So it was very cool to go to some of the museums and see the the ruins. And I was also lucky enough to go to the Karolinska Institute, which was really amazing. So it was quite a jam-packed congress. There was a lot of urology. But for today's talk, I thought of the four topics that I'm going to focus on that were really interesting sessions. The one is on post-prostatectomy radiotherapy. There was a very interesting debate about whether you should treat the primary and metastatic hormone-sensitive prostate cancer. In terms of the latest trials, there was the Fast Track 2 trial that was presented, which relates to stereotactic radiation in RCC. And then a very hot topic in bladder cancer is the role of biomarkers, particularly CT DNA. So I thought I'd touch on that. So starting with the first topic, which is post-prostatectomy radiotherapy. So this was a plenary session that was chaired by Jochen Waltz, who's a urologist. And there were two excellent talks, one by a radiation oncologist from France, and then a second talk by a urologist from the UK. So let's start off with a case. So if you have a 60-year-old man who's had a robotic prostatectomy, and he's got an undetectable PSA post-op, you look at his histology, it's a pathological T3, Gleason score of 8 with positive margins. What would be your approach to manage this patient in the post-op setting? And I think the important question you need to ask yourself is, what is this patient most likely going to die from? Is it from a PSA relapse, or is it from metastases? And I think we can all agree that patients like this who have high-risk features are most likely going to die from metastases. And so that should be the aim of your treatment, to try and prevent systemic relapse. Now, biochemical relapse is quite a heterogeneous space, and they've proposed 4 main reasons why patients relapse. So firstly, local residual disease, which may be from, having positive margins. Patients could harbor micrometastatic disease within lymph nodes or beyond. Some patients have very biologically indolent relapse. So they have delayed relapse, that's a very slow rise in their PSA. And then other patients have very genomically aggressive relapse. And so each state may actually require a different strategy. So I just thought to revise some important definitions in terms of the 2 post-op approaches. The one is adjuvant radiation. That's where you give radiation basically immediately after surgery to patients who have poor histological features, so bad histology. But the patient has no sign of cancer, no recurrence. They have an undetectable PSA. And radiation is given once the patient's recovered from surgery. Whereas salvage radiotherapy refers to when you give RT post-prostatectomy at the time of biochemical recurrence. So that can be months to years after surgery. So a patient who has had an undetectable PSA that now starts to increase, or it could refer to a patient who has PSA persistence. And the terms early and late just refer to when that radiation is delivered according to the PSA level. So early salvage between 0.2 and 0.5, and late salvage when it's more than 0.5. Now, the whole thinking behind giving adjuvant radiotherapy was always to try and prevent biochemical relapse. But we know that these patients are going to more likely die from distant metastases. And if you look at the evidence, which is quite old now, adjuvant radiotherapy is never really shown to improve metastasis-free survival and overall survival. So these were papers back from 2014, showing patients that had quite high-risk features, so pathologically T3, T4 disease, high Gleasons, that were randomized to wait and see versus adjuvant, and no benefit in overall survival. We have the same data from Bola et al., also from 2014. If you look at the curves, no split in the curves. Once again, no meaningful benefit in overall survival for adjuvant. But is adjuvant radiotherapy still recommended in maybe some patients? This is a very interesting paper by Tilke et al. So it's actually a cohort of 26,000 patients who were followed up, and they looked at their risk of death. So they compared patients that got adjuvant radiation to those that got salvage post-prostatectomy. but these were patients that were pathologically node positive, so N1. And what you can see in terms of all-cause mortality or mortality, that patients that got adjuvant radiotherapy had significantly lower mortality compared to salvage and those that didn't receive RT, which suggests that there may be some patients that actually do benefit. And this benefit was actually most pronounced in patients that were heavily node positive, so patients that had 4 or more lymph nodes. So potentially there is a role, but remember, this is just a cohort. It's not a randomized trial, so maybe not the most robust evidence. If we look at the EUA guidelines, that also has changed from last year. So in 2025, high-risk PN0 patients, it was a strong recommendation to actually give adjuvant, whereas now in 2026, that recommendation has been changed to weak. There actually hasn't been any new trials published in this time, but what it tells us is that adjuvant radiotherapy is no longer considered standard of care. So early salvage, we can safely say, is the standard of care in the post-op setting. We've got enough data, good evidence from the 3 trials, which I'm sure you all know quite well, the radicals, the GETAG, and the RAVES with the artistic meta-analysis. And I think even in terms of toxicity, we know that early salvage is quite tolerable compared to adjuvant, which can be quite toxic. Now, what about ADT? Should you add ADT to salvage radiotherapy? And the answer is yes, in some patients, and it depends on the PSA level. So in patients that have PSAs of more than 0.5, there is a benefit for giving 6 months of ADT. But for patients that have low PSA levels, there actually is not such a benefit. And actually, ADT, which we know can induce cardiac events, can actually be harmful to patients. So in this randomized RTOG trial, where they used bicalutamide, in the patients that had PSA levels of 0.2 to 0.3, so low levels, the death from other causes was 4 times higher in the ADT group because these patients had higher events, cardiac events, and neurological events. So I think something that's really important to consider, especially if patients have comorbidities. And why this level of 0.5? So there's been the recently published Poseidon meta-analysis, which included about 6 trials that looked at salvage with ADT. And what you can see is that it's only when the PSA level is between 0.5, goes above that, do you see a split in the curves, indicating that there is actually a benefit with a statistically significant p-value. So then at this level, there is actually a benefit in terms of overall survival. But below this, you can see that there's no difference in the curves. What's also very interesting about this paper is they looked at pathological risk factors, so things like T stage and Gleason, and that actually was shown to not be a significant factor in benefiting from ADT. In fact, the only thing that is most important is the PSA level. So at the end of the session, somebody stood up and asked, well, why are we even treating high-risk patients with surgery? Should we even be treating patients because of this risk of requiring, all this multimodal treatment? And I suppose it's quite an interesting question, and it depends who you ask, oncologist or urologist. But it was Joachim Walser answered, who's a urologist, and I thought he answered quite well. And what he said was there's 2 ways of thinking about it. So, of course, offering external beam, yes, you can avoid multimodal therapy and potentially have better quality of life and side effects. But remember, these patients need 3 years of ADT if they're high risk and they're getting radiation. So if you offer surgery, you could potentially avoid long-term ADT in about 1/3 of patients, which can be quite significant if patients have comorbidities, obviously at the price of potentially needing multimodal. We know that surgery is a staging procedure, so that gives you a lot of other prognostic information. From all the trials, we know that toxicity from salvage is actually quite acceptable. And so having the strategy of de-intensifying treatment, so offering surgery up front, and then monitoring patients, and then intensifying treatment later on with salvage is actually quite a reasonable option and should be considered. So I think this question of should high-risk patients have surgery is an important one because the question is surgery truly a monotherapy in high-risk disease, or does all high-risk patients, will they all require multimodal at some point? So this is a database, quite a large cohort. They included 3,000 patients that underwent prostatectomy and extended pelvic lymph node dissection for high-risk disease in 15 tertiary centers, and they risk stratified them according to the STAMPEDE criteria, so PSA, T3, T4, and Gleason's of 8 to 10. And they use the number of risk factors to actually look at cancer-specific survival. And what you can see is that patients that have 0 to 1 risk factors may actually do very well with surgery, have good local control, have a 10-year cancer-specific survival of around 95%. So really good outcomes with no other treatment. But as soon as you have 2 to 3 risk factors, then you can see that the cancer-specific survival drops quite significantly with surgery alone. And so these patients would likely need more than just surgery. And this kind of echoes what the EUA guidelines say, that for high-risk patients, you can offer radical prostatectomy to selected patients with clinically node-negative disease as part of multimodal therapy, but very important to counsel patients. Besides risk factors, they also mentioned that there are certain other biological factors that you can use to predict whether someone's going to do well with surgery. So actually looking at the volume of disease, patients that have lower volume high-risk disease is actually a favorable feature for surgery. The type of imaging that you use. So if you're using PSMA PET, we know that this kind of imaging is much more sensitive and specific compared to conventional. So if you have a negative metastatic screen, you can be sure that this patient's not harboring mets, and these patients would likely do well. However, on the contrary, certain biological factors like histology, patients with cribriform pattern, intraductal carcinoma, patients with aggressive molecular features like P10 loss, BRCA mutated patients. We know these patients have biologically more aggressive disease and will likely require or could potentially progress to systemic relapse, and therefore maybe not such a great candidate for surgery because they would likely require multimodal treatment. So the summary is that not all high-risk disease after prostatectomy carries the same risk of systemic failure. So what does this mean for us and how we would apply this in our setting? So in our setting, we do offer surgery to high-risk patients, but I thought introducing this risk stratified approach is something that's really important and something we should consider in our protocol, taking into account the number of risk factors, but also looking at things like the volume of disease, like the histology, to make better decisions in the MDT about who should be offered surgery. Our approach has always been to offer kind of observation and early salvage. We hardly offer adjuvant radiation, but there is a role for, I think, patients that are heavily node positive and for patients that may not be able to follow up closely. The one thing that will change is the role of ADT in the clinic. So I've been giving ADT to everybody. And now I know that it's actually only patients that have a PSA of more than 0.5 that should be getting 6 months, and that the patients that have lower PSAs can actually not have ADT. Okay, so that was the first section. This is just a picture of Stockholm at night, 10 o'clock. It gets dark very late, so it's beautiful to walk around the city and nice city views. Okay, so I'll go on to the next topic, which was a very interesting debate that they had about whether you should treat the primary in metastatic hormone-sensitive prostate cancer. Should it be for all patients with metastatic hormone sensitive prostate cancer, or only a few? So the arguments against the motion is stuff that I think we already know, the big trials, the HORAD, the PEACE, and the STAMPEDE, which if we look at the overall population, where they compared ADT and ADT plus RT to the primary, did not meet its endpoint. So all these trials were negative in terms of showing that radiotherapy gives you a benefit in terms of overall survival. It was only in the subgroup analysis of the STAMPEDE where they divided patients into low and high volume, where the low volume patients were shown to actually have a benefit. Remember that these patients were staged with conventional imaging, so CT and bone scan. So the urologist that was arguing against this actually also said that if we want to look at a local treatment to help with local symptoms, you should actually even consider surgery as an option. And this was a paper published in 2021 where they looked at local event-free survival, and you can see that prostatectomy actually offered the best local event-free survival, with radiation actually being the worst. But this was just a cohort. It wasn't actually a randomized control trial. But what did the guidelines say? So the EUA clearly says that you can offer RT to low volume based on the charted criteria. ESMO says the same thing. ESMO does also mention high volume, that it can be recommended for high volume, given that RT to the primary has been shown to prevent severe GU symptoms, and that comes from the PEACE 1 data, but this is category B. NCCN also shows that low volume can be treated with EBRT, but they don't mention anything about radiation in high volume disease. When you ask the experts, so the APCC conference, which is a really great conference where they get all the prostate cancer experts in one room, ask them clinical questions and they vote. So the question was, for patients who have high volume metastatic disease, would you recommend local radiation to the primary in a patient who doesn't have relevant local symptoms? You can see 44% of experts would say no, but there are quite a significant number that would consider it in patients who have bulky local disease. Then the argument for the motion, meaning we should give radiation to everybody, was also a very interesting one. So just to understand a little bit about the biology of prostate cancer, we've always known or thought that you've got your prostate, which sheds cancer cells, and those cancer cells go and deposit mets, and that's called forward seeding. But what we actually know, what actually happens is that there is actually a bidirectional relationship. So yes, you've got cells from the prostate going out, but you've also got cells coming back to the prostate, and you get the self-seeding. So the prostate actually becomes quite a heterogeneous, biologically diverse area. And it's a reservoir that's actually got active cancer in it. So do we really want to just ignore this area completely? And they presented a very interesting case. So a 77-year-old retired ENT surgeon who had a Gleason score of 9. His PSA was 800 at diagnosis. And on his PSMA PET, it showed uptake in his prostate, lymph nodes, vertebra, ribs, pelvis, and femur. So quite high volume disease. So he was started on ADT in January and darolutamide in February. And by April, he had a really excellent PSA response. So his PSA went from 800 down to 7. So more than 99% reduction in the PSA. You can also see that his imaging, he had a whole body MRI, also suggested that he had an excellent response to treatment. But when you look a little bit closer, so when they looked at the pelvic bones, they measured the mean ADC. And you can see that the mean ADC went from 900 to 1,400, suggesting a decrease in cellularity within the bone and indicating likely tumor cell death and a good response, so a great response in the bones. But when they looked at the prostate, the mean ADC remained basically unchanged, was around 900, suggesting actually quite a hypercellular state, and that actually this disease didn't respond as well. So resistant disease to the hormone therapy. So even though the patient has had a beautiful response on imaging into the bones, if you actually look closely, the disease in the prostate was actually still quite significant in terms of harboring residual cancer. So quite an interesting thought. The other thing that needs to be mentioned is side effects. And they actually said we should stop using the word toxicity with radiation because it just sounds so bad. And it is. It's really quite, I think it's changed a lot over the years because of how radiotherapy has evolved. If you look at side effects overall, radiotherapy actually has the lowest side effect burden if you compare it to docetaxel, long-term ADT, ARPIs. Side effects from radiation are also transient, meaning they resolve often. And if you look at the data from the Stampede, the patients that got RT versus those that didn't, grade 3 toxicity was exactly the same, 39 versus 38%. Same with the piece 1 data. It actually showed a reduction in the GU side effects. So toxicity is actually not, it's a very well-tolerated treatment. If we look at the piece 1 data, and we look at why they've said that GU side effects improve adverse, radiotherapy improves GU adverse events, you can see in patients that got no RT versus those that got RT to the primary, adverse events were a lot higher in those that didn't. However, you have to analyze this with caution, because if you look at what they classified as events, they put in radiotherapy and a TURP. Now, obviously, patients that had radiotherapy would not have received more radiation, so there would be no re-radiation. And secondly, with TURPs, we know that we don't do TURPs in patients that have had radiation because of the complications. So those patients actually, it did skew the analysis. And if you actually remove that, toxicity is kind of similar between the two groups. So basically, in summary, in terms of prostate RT in metastatic hormone sensitive, if you've got low volume, this should be offered routinely. We've got enough evidence for that. And they say that in high volume, we need to start considering it for certain patients to offer local control and to prevent morbidity. And they ended off with this very nice analogy. So they said, imagine running the ESTRO 5K and you've got a walnut in your shoe. And that walnut is the prostate that's untreated, right? So it's there seeding, shedding cells. Every stride you take is a cycle of an ARPI that's trying to fight this burden of disease. The finish line is trying to achieve durable metastatic control. But that's going to be a lot harder with the walnut in your shoe. So if you treat the prostate, that takes the walnut off the shoe and could make the fight against this burden a lot easier. So I thought that was quite nice and a quite nice way of putting it. At the end of the day, the people against the motion won. So of course, you shouldn't offer RT to everybody. In terms of our protocol, we do offer it to low volume patients. But just remember, if you are using PSMA imaging, what hasn't been defined is how you define volume of disease on PSMA imaging. That terms or that criteria is based on conventional imaging. So you actually shouldn't deny patients that you think would be low volume on conventional, and they have a few kind of mets that may be sub-centimeter, not that bright, likely would have been negative on conventional. You shouldn't deny patients RT because of that. But it is a space that's not clearly defined because nobody has a clear definition of what you should use with PSMA. And I think this idea of, treating high volume patients has become quite interesting. We should consider it in patients that have bulky prostate and symptomatic primaries. So that is something that potentially would be included in our protocol. Okay, so that was on that. I did go to the Avicii Museum because I'm a big Avicii fan, and that was quite nice to see in Stockholm. Okay, I'm going to go on to the third topic now, which is the Fast Track 2 trial, which is relating to RCC. So this was the final results that was presented. And we know that the incidence of renal cell carcinoma is increasing, mainly in patients over the age of 70. And these patients, these older patients, tend to have a higher cancer-specific mortality. It's about 3.8 times that of the average mean age of 65. So surgery, we know, is standard of care. So partial nephrectomy, nephron sparing is ideal. From a database in the US, the NCI's recent database, what they actually saw that most patients over the age of 65 actually get a total radical nephrectomy. Only less than a third of patients actually end up having a partial nephrectomy. So SABR, or stereotactic radiotherapy to the kidney, could be an alternative that ticks all the boxes, right? So it avoids a general anesthetic. It can treat perihilar tumors, which sometimes may be tricky with tumors around the calyx and doing thermal ablation, even achieving a partial. It's amenable to large tumors, and it is totally non-invasive. So the objective of this trial was to assess efficacy of SABR in the first multi-center phase 2 trial of non-surgical management of primary RCC. And this was patients that either failed or were not suited to active surveillance or surgery. So patients had to have a biopsy-confirmed RCC. They were medically inoperable or high risk for surgery. It was an MDT decision was made that they did actually warrant active treatment, and they had to have an EGFR of more than 30. They excluded very large tumors over 10 centimeters and those abutting the bowel. So in total, they recruited 70 patients. The median age in this trial was 77, so older patients. You can see the BMI 32, so also larger patients, and patients that had comorbidities. About 70% of patients failed active surveillance, so they had some serial growth on interval imaging. And this was just the distribution of the T stage. So most patients were T1B. There was only one patient that was actually node positive. So the treatment was, if the tumor was less than 4 centimeters, they'd get a single fraction of RT. And if it was more than 4 centimeters, then they would get 3 fractions. So the outcomes, so this was a 5-year follow-up. So local control rate, 100% at 5 years. Cancer-specific survival, also 100% at 5 years. So no patient died from their cancer during the lifetime of this trial. In terms of freedom from distant failure at 5 years was 88% and up to 78% at 7 years. And then in terms of kidney loss or kidney function, what was interesting is that there was a reduction in kidney function. So average was 61, that dropped to about 46. And that was in the first 2 years, 24 months. But thereafter, it actually remained very stable, up to 8 years. So quite impressive. There was only one patient who required dialysis, and that was a patient who had quite a large tumor, about a 6 centimeter tumor, and had a baseline EGFR that was 34. In terms of side effects were actually quite well tolerated. Only 7 patients had at least one grade 3 adverse event. There were no grade 4 or 5 adverse events. And very interesting, side effects only occurred up to 9 months. Thereafter, there were no late side effects. And I think that's really important because toxicity and late RT side effects is something that everybody worries about. But with stereo, it's completely different to conventional radiation. It's highly conformal to the target, missing a lot of the normal tissues. So you don't get the side effects that you get with kind of traditional external beam. And that's very important. So where does this leave us in 2026? So SABR is a category 2A recommendation from NCCN. The EUA also recommend SABR for medically inoperable patients. And there's a lot of work that's going to be in the space, really exploring the combination of immune therapy with SABR for RCC. So the outcomes of this trial support the design of future randomized trials, and I think we're going to see a SABR versus surgery trial for primary RCC. That will be quite interesting. So in terms of the discussion, is SABR for RCC a new standard of care? Undeniably, yes. There has been recent large meta-analysis that have shown sustained excellent local control rates, so about 95% at 5 years for inoperable patients or patients that decline surgery. So what does this mean for us? So we know that in our setting, we've got quite limited options for RCC. We do also have patients that have quite significant comorbidities, elderly patients who may not be that robust for surgery, even though they've got localized disease. And hopefully SABR will become a treatment option that we can offer our patients because we hope to implement our stereo body radiotherapy within the next year. So that would hopefully be something we can offer our patients. Okay, so that's the third topic done. Stockholm and Sweden is also famous for ABBA, so that was really nice to go to the ABBA Museum. They've got these avatars that you can dance and sing along with ABBA, which was quite fun. So that was cool. And then the last thing that I wanted to speak about is relating to bladder cancer. So this is a very hot topic, biomarkers in bladder sparing strategies. So there's different types of biomarkers. You've got tumor biomarkers, which may identify patients that have more aggressive disease or that are more sensitive to certain treatments. And then you get liquid biopsies, which identify whether there's residual and also determine your risk of relapse. And that can be used to monitor patients over time and after treatment. So for bladder preservation, biomarkers must answer two questions. Firstly, is there residual disease in the bladder? And that's where urine tumor DNA comes in. And then is there persistent systemic risk? And that's where plasma circulating tumor DNA comes in. So in the future, bladder preservation will likely incorporate these biomarkers to combine both local and systemic molecular assessment. So can circulating tumor DNA actually guide treatment? So in the IMvigor study, which was an adjuvant study, so patients post-cystectomy that got randomized to atezolizumab, it was overall a negative study, but when they did a post-hoc analysis and they looked at the ctDNA, they found that in patients that were ctDNA positive post-cystectomy, they had quite a significant benefit in receiving atezolizumab, which is an immune therapy, compared to those that were not. So this was quite an interesting finding, which then led to the IMvigor 11 trial, where they specifically selected patients that were ctDNA positive post-cystectomy. And the same results were shown, that the patients that received atezolizumab benefited more than those that didn't, that those that got placebo, indicating that it can actually guide treatment. So this was a benefit seen in both disease-free survival as well as overall survival. What's also very interesting is that patients that are ctDNA negative post-cystectomy do very well. And this is seen that patients that had a recurrence-free survival rate of 95% at 12 months, that were ctDNA negative, that received no other treatment, no other adjuvant treatment, which suggests that you could potentially use this to monitor and even de-escalate treatment in patients. So this is really going to be, I think, quite informative. The thing about plasma ctDNA is that it tells you your systemic risk, but it doesn't tell you if there's residual disease in the bladder. So it's not actually sufficient to tell you about local residual. And that's where the urine tumor DNA comes in, because that actually may inform whether there's residual. And in this study, in patients that had a clinical response, they looked at the urine DNA detection, and about 42% that were thought to be clinically complete response actually were positive or had detectable urine tumor DNA. And when they plotted that on terms of bladder intact survival, you can see that the patients that had detectable urine DNA had much lower bladder intact survival compared to those that were negative. So I think very interesting work. The take home is that we're going to need to use both the plasma and the urine to actually inform decisions. It's not just going to be one biomarker, and I think this is going to become quite a big thing in bladder cancer. We have a blood biopsy repository now in our department, and so liquid biopsies is going to become a big thing in oncology, and it is going to be a potentially good area to do some research, I think, in our setting with our patients with all of this. So quite intriguing. Okay, so that's basically it. I'm happy to take some questions, but I just wanted to leave you with one conference that I think will be really valuable for urologists to attend next year. So the APCC is usually the Advanced Prostate Cancer Conference that happens every year in Lugano in Switzerland. And like I mentioned before, they get all the rock stars in prostate cancer to come together. And what's different about this conference is that they don't present papers and talks. They present clinical scenarios and questions to the experts, and everyone votes, and then they have very interesting discussions around clinical. So it's not about what the guidelines say, it's actually about what people are doing in real life and what experts do in clinical practice. And for the first time next year, they're having a localized prostate cancer meeting, which is said to be quite going to be quite good. So I think that it's something definitely to consider as a potential conference for next year. Thank you very much, and I'm happy to answer questions.
Let's see if there's any questions in the chat. Anything you can say? Just see. Anything in the chat? Okay, good. Thank you, Santhuri. Do you have any questions on the floor? I don't think we have any questions in the chat at the moment. I just want to say thank you this morning for the talk. I think everyone enjoyed it quite a lot. Very insightful, and thank you for telling us about all the latest that there is in the realm of oncology, you know. I think we have a question from Masi, sorry.
Okay, I think we're still on, they can hear us.
Can it? I don't see it yet. Okay. Is the meeting still?
Just check bottom right and see Zoom.
Yeah, but it's not. Is it on?
Yeah.
Okay.
I remember if you need escape, it's going to show you the top toolbar if you go to the presentation and you need to escape it already.
Oh, okay.
Toolbar better. Just open up the PowerPoint. And we escape on the keyboard. Should
Okay.
There is
There we go.
good. Technology problems here. Just a quick one, Santhuri, just to maybe reflect on the fast track trial. Just in my view, you know, I mean, I did look at the paper as well at some point, but just in my own experience and the patients we see, especially in South Africa and this part of the world, once we say you're not fit for surgery and you're not fit for any intervention, usually it's a patient, especially at the extremes of age, above the ages of 70, 77, with all the comorbidities. It's usually a patient you can predict will demise in the next 3 months or so. Like it's usually patients at the extremes of life. It just hits me odds that they could follow the same patients up to a 3 or 5 year period, apart from the cancer, but not die from anything else. I mean, how do you interact with that?
Yeah, it's interesting because it, as you said, it was quite an older population, average age of 77. But I mean, that is also, it was a trial done in Australia as well as Amsterdam. So that's were the sites which probably reflect the population differences in Europe, which is generally an older population. I'm not too sure about Australia, but I mean, it just, I think it reflects differences in population. But I think quite impressive results still that they were able to show and demonstrate long-term, at least 5-year follow-up. You know, I think that's quite significant. That's a long time. And yeah, I suppose it's got to do with difference in comorbidities, lifestyle, and all those things that affect life expectancy between countries, right? But I think they were able to show, at the end of the day, you want long-term benefit. That's kind of the most important endpoint, and that's what was demonstrated. Yeah.
No, thanks for that. The reason I ask is, I mean, for my prep, I had to compare sort of the minimally invasive options.
Yeah.
And I was just looking at the mechanisms of how they work. And to be honest, I was quite impressed with the stereotactic radiation in that, in difference to the other ones. It actually works on the DNA fragments it, you know.
Yes.
So I was quite impressed with that if you compare with cryo and thermal.
Absolutely, yeah.
So just for those reasons, in my mind, just the mechanism, it does sort of offer hope.
Absolutely, yeah. And I think also really good toxicity, you know, toxicity that's tolerable, which is always important because older patients tend to be more sensitive to side effects of chemo and radiation just in general. And I think that was also very important in this paper, that toxicity was manageable and not as severe as we think that RT is. Yeah, so that's, I think, quite positive.
Okay, so I have a question in the chat. Interesting that SRT showed 100% control in the primary, but only 75 to 80% freedom from metastatic disease. Makes me wonder how the local control was assessed from Danilo.
Yeah, I think so. They did. So they looked at these patients were followed up with serial imaging. So in the first 2 years, it was actually quite close. I think it was like 3 or 6 monthly, and then thereafter the imaging got less intense, 6 to yearly, to kind of assess local failure. Yeah. But we know that this is a disease that does like to metastasize. And of course, you're not removing the organ. When you irradiate an organ, you change the tissue structure, and you hope that you've eliminated all the tumor cells, but the organ still remains there. There's always that potential nidus for spread. Yeah.
They don't require to that.
I can't remember. I'll have to just double check if they biopsied. I don't. I'll have to double check that. I can find out and then just let you know.
Yeah. Good. Okay. I think in the interest of time, we will park the next talk for a different day. But we want to say thank you once again, Santhuri, for an excellent talk. I think everyone, like I said, enjoyed it this morning. Thank you everyone for joining this morning, and we'll see you next week, Friday, for the next webinar. Thank you.